This is Charles Clinton with the Heart of Medicine, and this is going to be a quick video regarding the ABIM Pearls number 17. So we're up to 17 videos now. We've been doing this every single day, and the idea is just to get it done. We're not so concerned about the background, the editing the videos. No, just get it done and get it out of the way. If it works for anyone here, I'm glad for you. If not, it works for me because I'm also sort of testing my weak spots as well. The idea for these videos is to improve anyone who wants to work on or learn a little more internal medicine, me specifically for the internal medicine certification examination, which is coming up shortly. And yeah, that's about it. So let's get on to the first question. So first clinical pearl here is basically telling you, even if you have a normal mini mental examination result, which 26 out of 30 is still within the normal range, you can still have dementia. So that's a very important point because most people will just not think about dementia if the mini mental is normal. But remember that the mini mental will be directly proportional to the level of education a person has. So if a person, let's just move this a little bit, if a person has a only high school degree, maybe an average mini mental test, which would be normal for that person, would be about 26, 27. If a person has postgraduate degree, it means that the mini mental on average will probably be around 29. So that's the main thing. This patient forgot some things, but the most concerning thing in this patient is that he got lost in his own neighborhood where he has lived for the past 20 years. That's not normal, of course. So that's definitely gonna be a problem. If this patient isn't in drugs, it's gonna be something like dementia or maybe delirium, but there's no option here of delirium. It's not talking about fluctuating consciousness. So the answer is Alzheimer's dementia here. And we'll see why not mild cognitive impairment. So let's go to the educational objective. Very mild dementia, or those who are highly educated with dementia, can have normal mini mental state examination. So as I mentioned, high level of education, you would expect a mini mental of 29, and maybe just finish high school and that's it. You might expect a 26 on average. Other than that, why isn't it mild cognitive impairment? Option D, because normal aging and mild cognitive impairment should not significantly impair daily activities. So yeah, if this patient got lost in his neighborhood, that's something to consider. Next question here, let's see what's the clinical pearl. This clinical pearl is just telling you, okay, this patient has cirrhosis, so you have the physical examination findings for cirrhosis. It isn't, there is some ascites, but it's not saying that there's abdominal pain or there's any specific reason for you to drain that, do a paracentesis. And labs aren't that bad. Just yes, there is hyponatremia. INR is 1.8. There's no encephalopathy, so it's not acute liver failure. But yes, you do have all the findings for cirrhosis, and then it is asking you what is the best next step in management of this patient. So you want to treat these patients, with higher doses of spironolactone compared to furosemide. So that's what you wanted to give this patient right here. So management of ascites due to portal hypertension. Well, in this patient specifically, we didn't have to do the patient did have a diagnostic paracentesis. Okay, showed only neutrophils 88. So you know that for you to think about spontaneous bacterial peritonitis, SBP, you would suspect with neutrophil count above 250 or leukocyte count above 250 with at least half of those being neutrophils. Only 88 neutrophils, that's not enough for that. And they gave you a total protein, so you can definitely calculate the serum in albumin, the SAAG, which is the serum ascites albumin gradient. If that is above 1.1, you're usually thinking about a sort of transudative process or portal hypertension. So let's see, if the SAG is more than 1.1, more than 1.1, you check, is there alcohol cessation, yes or no? Avoid NSAIDs, ACE. Well, you do have to do these things. So if the SAG is more than 1.1, you, of course, ensure alcohol cessation. You avoid NSAIDs, ACE inhibitors, ARBs, and you restrict sodium to 2 grams per day, because if SAG is above 1.1, it is portal hypertension. And those are the therapeutic things to do initially. After you do that, then you check a serum sodium. If the serum sodium is less than 120, you do fluid restriction, hypertonic saline, and or vasopressin receptor antagonist. If the serum sodium is above 120, then you consider these other medications, which were the right answer. So spironolactone 100 milligrams plus oral furosemide 40 milligrams daily. You increase the dose weekly as needed to a maximum dose of 400 milligrams of spironolactone to 160 milligrams of furosemide. So then you check if the patient still has ascites. Is the ascites refractory? Yes or no? If the answer is yes, is it associated to hypotension? If there is no hypotension, you do large volume paracentesis with albumin infusion for more than or equal 5 liters removed. You give 5 grams per liter, so it's going to be at least 25 grams of albumin. And if there is hypotension, you do midodrine, okay? Or you can also do, if the patient is in the ICU, you can do norepinephrine peripheral, IV vasoconstrictors. And then you consider TIPS or liver transplant. Okay, so that's the information we have for this question. Now we went through the whole algorithm and how to treat it. And why wasn't it referral for liver transplant? Because it should be an advanced cirrhosis. This patient is still being worked up for cirrhosis, so you first have to see how he does on the medications and all that. What else can we find here? That's about it. Of course, you never give ARBs or ACE inhibitors in patients that you have suspected in portal hypertension, because it will just make things worse. It will reduce GFR and worsen renal failure. So that's that question. Now we're going to go to the next question. This next question is about a patient 56-year-old male who has smoked for a whole lot of years and now is having hoarseness and never had hoarseness in the past in the absence of any upper respiratory tract infection sort of symptoms, and also is having some right ear pain or right ear discomfort, which is quite vague. So basically, the patient had a evaluation, otoscopic evaluation, showing normal findings, and the question is, what's the next best step in management for these patients' symptoms? So the answer was complete otolaryngologic evaluation. Okay. Why? Because sometimes you can have something compressing right there. It could be a tumor, so you don't want to just let this go unmissed, right? So that's the right answer. It says hoarseness is characterized by coarsening, coarsening of voice quality, and this typically due to abnormalities in the larynx, such as edema, hemorrhage, laceration, mass lesions. Most causes of acute hoarseness are benign. However, patients with symptoms lasting more than 2 weeks, or a history of tobacco or heavy alcohol use, systemic symptoms, stridor, dysphagia, or referred ear pain require referral for consideration of laryngoscopy. So that's why that was the right answer. And let's see what else we might be missing here. Findings that suggest serious etiologies of hoarseness. So we already talked about some of them, which were the risk factors such as the smoking, the alcohol abuse, add in their immunocompromised state, or persistent hoarseness after trauma or surgery. And you have several clinical findings that when you add them to hoarseness, they are very concerning, such as hoarseness that is refractory, it is worsening, there is weight loss, there is stridor, throat pain, hemoptysis, dysphagia, ear pain, shortness of breath, neck mass, and that's about it. Let's go on to the next question. This next question is a patient. They're basically asking you here what to do in a patient with thyroid storm. I didn't get this one correct because I didn't know that the patient had hyperthyroidism and had been given radioactive iodine. And then on admission, you have similar lab findings. And I just thought, dexamethasone. I have read about that. I think it decreases the conversion of T4 to T3, and maybe we have to give that. And I was on the fence between that option and, of course, this other option. So the right answer was propranolol and propylthiouracil. Yes, dexamethasone is a good idea, but you give it afterwards. You first want to control the thyroid storm symptoms with beta blocker, non-selective, and propylthiouracil, and that's about it. So clinical features of thyroid storm, you have, first of all, precipitating factors such as acute illness, acute iodine load, thyroid or non-thyroidal surgery, some clinical findings, fever, pretty elevated, tachycardia, hypertension, heart failure, atrial fibrillation, neurological things such as agitation, delirium, seizure, goiter, lid lag, etc. Treatment, so beta blocker, and that's to decrease the adrenergic manifestations. I don't know why I feel like these are just sideways on me. So propylthiouracil followed by iodine solution, and let's see what else. And that decreases the hormone synthesis and release. And then glucocorticoids to decrease the peripheral conversion T4 to T3 and avoiding triggers, of course. Okay, so that's the main thing. Now let's go on to the next question. This next question, main thing is, this was a tough one for me because it's just asking you about these little tick-borne infections, and sometimes they're tough. Or also when they ask you about to distinguish, for example, between chikungunya, dengue fever, yellow, all those sometimes get complicated. But in this case, let's focus on this question right here. So as you can see, I had jotted down just to Babesia and Ehrlichia. So the main thing maybe to remember here is that Ehrlichia and Anaplasma, they're about the same thing. Ehrlichiosis, anaplasmosis, they are about the same thing. Ehrlichia, I did not mark the answer because I was expecting that any question they asked me about Ehrlichia would have the inclusions, right? We'll see them in a moment, but I didn't see any inclusion, and I'm like, no, this isn't Ehrlichia, right? But also Babesia has, I think, the Maltese cross in the red blood cells, if I'm not incorrect. Correct me if I'm wrong. So, I just wasn't sure about this answer. Let's see what are the characteristics. So, 34-year-old man, high fever, malaise, intermittent headaches for 4 to 5 days. Returned from hiking several days in wooded areas of Missouri. Temperature is 38.9 or 102 Fahrenheit. And basically, physical examination shows a faint, non-pruritic maculopapular rash confined to the trunk without central clearing. The remainder of the physical examination is normal. Okay, so hemoglobin was fine, but platelets and leukocytes were low. So basically, a rash, mostly like centripetal or in the thorax without central clearing, associated to leukopenia and thrombocytopenia, and also fever. So what they want you to think about is actually Ehrlichia. So let's see why. Let's see first this objective, which says Ehrlichial infection is commonly caused by Ehrlichia chifensis, human monocytic ehrlichiosis, and Anaplasma phagocytophilum, or human granulocytic anaplasmosis. Ehrlichiosis presents with severe and prolonged fever, leukopenia, and thrombocytopenia. Rash without central clearing is infrequent in both of those, in the Ehrlichia chifensis and very rare in the Anaplasma phagocytophilum. But it can happen, and I guess that's what the patient had. And doxycycline is the preferred treatment. Okay. So it wasn't Lyme, because if it was Lyme and they give you a rash, it will have it'll say maybe targetoid, or it's gonna say central clearing, right? So it wasn't Lyme. It wasn't. Let's see what else we have here. Ehrlichiosis is usually suspected clinically. Peripheral blood smear may show the characteristic intracytoplasmic inclusions or morulae in neutrophils. Indirect fluorescent antibody testing with antibodies specific to the organism is the preferred confirmatory test. Untreated ehrlichiosis can suffer serious complications such as seizure, renal, respiratory failure, okay, with increased morbidity and mortality. So patients should receive empiric doxy, which also treats Rocky Mountain spotted fever and often difficult to differentiate from ehrlichiosis in early stages. Okay, so maybe some differentiating factor, at least in the test, is that Rocky Mountain spotted fever is going to start in the extremities. It's going to be hands and feet. And this one, if it has a rash, the rash is going to be central and without, sorry, it's going to be in the thorax or centripetal without central clearing. Colorado tick fever, I've never seen this in my life, transmitted by the tick Dermacenter andersoni. I have read a little bit, but I didn't remember it. And occurs in the Rocky Mountain regions at over 4,000 feet elevation, so pretty high. Although this viral illness can present with similar symptoms, the patient lacks travel history to the mountains, making the diagnosis unlikely. Over 80% of patients with Colorado tick fever do not develop a rash. Okay. Now let's go on to the next question over here. This next question is important because what do you do in a patient with hypothyroidism? So clinical hypothyroidism, what's the next step in management? So before just going ahead and giving the levothyroxine, which happens often, for example, in clinic, this happens a whole lot of times. You have hypothyroid patient and you just make the diagnosis and you start treatment. But something they want you to learn is that if you have hypothyroidism, you want to first check that this patient is not, well, not all hypothyroidism. We're talking specifically of the secondary hypothyroidism or central hypothyroidism, which is the problem is here in your pituitary or hypothalamus, meaning that the TSH will be low. So TSH will be low and the thyroid hormones will also be low. So that would be central. When you have central hypothyroidism, there you have to check that this patient is not deficient in corticosteroids, because if you give levothyroxine to a patient already deficient on corticosteroids, you're just going to exacerbate it and exacerbate the corticosteroid deficiency and basically throw the patient into some sort of Addison's disease, and the patient might even die. Of course, it's going to become hypotensive, tachycardic, etc. So that's why you have to do a concentropin stimulation test, meaning something that is like ACTH that will go stimulate for corticosteroid secretion. So that's the main point for that question. I think we got the main, clinical pearl. And let's see. Yeah, I think it's, you don't check for low corticosteroids or cortisol with all hypothyroidism. I think it's mainly with central hypothyroidism, okay? And let's just make sure about that, okay? There's a good little table. We'll see it later. Central hypothyroidism, okay. Central hypothyroidism has similar presentation to primary hypothyroidism. Okay, we already know that. Initial treatment for hypothyroidism prior to diagnosing and treating concurrent adrenal insufficiency may induce adrenal crisis. Okay. Although this patient's morning cortisol level is within the normal range, a low to normal cortisol level may be seen frequently in adrenal insufficiency. A concentropin stimulation test is recommended. Okay, so let's wake up a little more so we can finish these remaining 7 questions. This other question is basically a 70-year-old woman who has leukocytosis, 25,000. Look at all these lymphocytes, right? It has flow cytometry, which was done on peripheral blood smear, also smudge cells on peripheral blood smear. So when you take all this into context, this is called CLL, chronic lymphocytic leukemia. Why? Because CLL usually happens, I believe, in older age people. It is clinically like indolent. It's associated to smudge cells. The diagnosis is through flow cytometry, which this patient had. And as you can see, there's not many physical findings going on. It's just this lab abnormality that was found after the patient was being worked up for a knee replacement. So the question is, what do you do? So I just proceed with the knee replacement because this is usually, of course, indolent. So that shouldn't alter the time span or time management. So how do you diagnose CLL? You do flow cytometry, co-expression of B-cell antigen CD19, 20, and 23, and T-cell antigen CD5. There might be a low surface immunoglobulin level, either kappa or lambda IGLC. Okay, and peripheral B-cell count is over 5,000. And indications for treatment so if you have systemic symptoms such as fever, weight loss, fatigue, night sweats, you treat, or massive progressive lymphadenopathy or hepatosplenomegaly, or progressive marrow failure, or autoimmune hemolytic anemia or thrombocytopenia unresponsive to steroids, or rapidly progressive lymphocytosis, doubling time in less than 6 months, or repeated infections. If the patient doesn't have any of those, you don't have to treat and you will observe. Okay, and that's about it for that question. Okay, let's go on to the next one. The other, of course, one of the clinical pearls from CLL is you just don't go to bone marrow biopsy almost ever. So that's a easy way they can trick you, because you're thinking, oh, this is leukemia, I'm gonna get a bone marrow biopsy. No, that's not it. It's gonna be flow cytometry, peripheral blood smear. And of course, you can then do some other genotyping, but that's the main thing for you to remember. This other question is important because it is Ogilvie syndrome. So it is looks like intestinal obstruction without there being an obstruction. So that is called Ogilvie syndrome. That's called colonic obstruction, I believe, or pseudo obstruction of the colon. And what do? You mainly observe, you do abdominal serial examinations, and of course, if there are red flags, you might have to intervene. So that was the right answer. I was between serial abdominal examination and a percutaneous tube cecostomy. I wanted to probably choose this one, but I didn't choose abdominal examinations because I saw the diameter of this colon. The maximum one was 11.3 centimeters. And I think I recalled from a C. diff infection that when you have toxic megacolon, the diameter is above 10 and there's like risk for perforation. So I was thinking to myself, no, like why would we just wait on this? This is way too dilated. Well, the answer was to do that. So we're gonna see why next. Ogilvy syndrome presents with marked colonic dilation without evidence of obstruction and frequently occurs in elderly males. Therapy is usually supportive with treatment of possible underlying causes. Neostigmine is indicated in patients who fail conservative therapy. Those who fail neostigmine or have contraindications may require colonoscopic or surgical decompression. So, acute colonic pseudo-obstruction, there you have it, the main etiologies. You can have electrolyte derangements or due to medications or neurological disorders or major surgery, trauma, or infection. Clinical findings, we already talked about most of it. Of course, if there's a lot of distension and gas, there's going to be tympanic percussion. If the bowels aren't moving, so bowel sounds are reduced. And if there's perforation, you'll have now guarding, rigidity, and rebound. Imaging will be X-ray mainly. Probably don't need a CT scan, but if you get one, you can see similar findings. Management is nothing by mouth, nasogastric or rectal tube decompression, neostigmine if no improvement within 48 hours. And why wasn't it cecostomy? So cecostomy was option C. Patients who fail neostigmine or have contraindications may require colonoscopy or surgical decompression, including percutaneous tube cecostomy. Okay. This next question was one of the quickest. As you can see, 34 seconds, we got it done. This one was just asking what is significant. So which of these different options was statistically significant? So the only thing you had to go check is which one of these crossed the null value, meaning which one crossed 1.0. So 0.86 to 1.31 goes through 1. So that's not significant. This one is 1.5 to 2.88. That has nothing to do with 1.0. So this is significant. This one is insignificant, so the only significant one was heart failure. It says relative risk is the risk of an event in the exposed group compared to the risk of the event in the unexposed group. A confidence interval that crosses the null value is not statistically significant. Next question over here. Yeah, this was another one that was sort of quick. As you can see, maybe, 47 seconds. This patient had some things on the lips. So you can see multiple brown spots on the lips and buccal mucosa. Whenever you see these brown spots on the lips, usually it's just one thing and they're guiding you towards that thing. And that's Peutz-Jeghers, right? Peutz-Jeghers, which usually when you see those things on the lips, you have to think, oh, maybe we have some polyps down there in the intestines, and this is high risk for cancer. Not only intestinal cancer, different cancers, but of these options here, which of the following is the patient most at risk of developing? It's going to be intestinal cancer. So, Peutz-Jeghers is rare autosomal dominant disorder with multiple hamartomatous gastrointestinal tract polyps, pigmented mucocutaneous papules, and increased risk of malignancy, both GI and non-GI. Increased surveillance for malignancy is recommended and includes colonoscopy starting at age 18, upper endoscopy, and small bowel series starting at age 8. Imagine how bad this is that at age 8 you're already doing these things. Early mammograms and testicular examination in boys under age 12. So yeah, pretty bad one right there. Okay, let's go on to the next one. This next question, yeah, this one was important. Let me just remember why. Thyroid hormone replacement thyroidectomy for patients with the disease. Okay. Yeah. So this was a patient basically that you were treating for. This patient had metastatic papillary thyroid cancer. He underwent total thyroidectomy 4 weeks ago. Now TSH is 2.5, and the patient is on levothyroxine to suppress TSH. So what does this mean? Is the patient adequately suppressed or no? It seems like the patient. Let's see what's going on. So thyroid hormone replacement indicated following thyroidectomy for patients with differentiated thyroid cancer to suppress TSH stimulation. Okay, of residual tumor tissue. For patients with limited or low risk disease, TSH should be maintained in the low normal to mildly suppressed range. In contrast, patients at high risk of recurrence, such as those with incomplete resection of the primary tumor or no metastasis, including this patient, require more aggressive suppression of TSH less than 0.1. Suppression of TSH in patients with high-risk papillary thyroid cancer appears to improve progression-free survival, but can induce a hyperthyroid state. Yeah, because you're given too much thyroid hormone to suppress the TSH, so that's going to generate hyperthyroid state, and this increases the risk of systolic hypertension, atrial fibrillation, and osteoporosis. Okay, that was the caveat. So the question was, the patient is at greatest risk developing which of the following conditions in the future? It was osteoporosis, correct. So they wanted to trick us with hypoparathyroidism because that was potentially associated to endocrine or multiple endocrine neoplasia type 1, because they're telling us that the father had a similar papillary cancer and the patient too, so you're thinking of type 1 papillary, type 1 multiple endocrine neoplasia. Let's see why it wasn't B. Transient hypothyroidism is common following thyroid surgery. However, permanent hypothyroidism occurs in only 3% of patients. Although the incidence may be higher after extensive surgery or anatomical disruption, this patient's surgery was without complications, and she has a low risk of hypopara. hypothyroidism. So we were talking about hypoparathyroidism. Okay, so I was thinking this question differently. Yeah, the most reasonable answer was that if you take out the thyroid, you could potentially remove the parathyroids, okay? But the incidence is sort of low, and I was just thinking something else with the multiple endocrine neoplasia. I was maybe complicating it too much. So let's go on to the next question. This one was basically asking you, which of the following laboratory changes would represent the greatest loss in GFR? And as you can see, whenever you have of course, creatinine is one of your best markers. So whenever you have that in the picture, that's probably gonna be one of the answers, because BUN is going to be an indirect marker. So increasing BUN from 10 to 20, this is pre-renal. Maybe the creatinine hasn't budged, and maybe it's a pre-renal kidney injury that is well compensated by the kidney, and then all is well. But if you have a rise in serum creatinine from 0.2 to 1.2, that's more than a 0.3 rise. Whenever you have more than 0.3, or a 50% rise in creatinine, that's acute kidney injury. And why did I choose that one over the next option? Because the next option, although the creatinine rose from 4 to 8, it doubled, it doesn't mean that it's going to be worse, because the patient was already horrible. With a creatinine of 4, you're already horrible. You already have basically terminal or stage 5 CKD, or grade 3 acute kidney injury. And the difference between a creatinine of 4 to a creatinine of 8 isn't that much, but a difference of creatinine, which was normal of 0.8 to now 1.2, that is more significant, okay? Here you have the logarithmic curve and how it starts going down, meaning that early AKI or a small change in creatinine will have a large effect on the GFR, while in advanced TKD, a large change in creatinine will have a small change on the GFR. And that's it for this question. Let's go on to this other question. This other question was giving us some interesting information, saying that this patient is having some specific symptoms such as weight loss. Weight loss, a new heart murmur, is febrile, okay? And they also describe the murmur. Heart sounds are normal, and they 2 out of 6 early diastolic murmur present at the right upper sternal border. Remember that this isn't a flow-related murmur, because the ones that are flow-related are usually systolic and not diastolic. So whenever you find a murmur all of a sudden, and any diastolic murmur, you have to go work it up. You don't have to go work up all systolic murmurs, because some of them can be physiologic. So yes, this is a diastolic murmur. Seems it's new. There's fever, and maybe there's a decoy here that wants just to confuse you, saying that 3 sets of blood cultures during the previous emergency department visit revealed no growth. That doesn't mean that the patient can have a culture negative endocarditis. So what you had to do, the next step in management, was echocardiographic examination, and culture negative endocarditis is the topic of basically this question. So etiology is usually infections, even if you don't have the cultures positive. So it means it's something you can't grow easily on the culture media material, such as Coxiella or Bartonella. Another one is Streptococcus, if antibiotics were already given, and fungal organisms, and the non-infectious causes of culture negative endocarditis, which are those associated with NBTE, non-bacterial thrombotic endocarditis. So you have rheumatologic disease, malignancy. Clinical presentation, usually subacute, no growth on 3 sets of blood cultures for more or equal to 7 days. Diagnostic workup, modified do criteria do apply. So you do the echo. You do a serology for Q fever, which was the one associated to Coxiella, a rheumatoid factor, urinalysis, maybe PET or cardiac CT, some cases. And that's about it for this question. Let's go on to the last one. Right before we go to the last one, there's this HACEK group, HACEK, sort of fastidious organisms that are usually difficult to culture and all, but are part of the causes to consider for infectious endocarditis. So HACEK is H is Haemophilus, A is Aggregatibacterium, Aggregatibacter, C is Cardiobacterium hominis, E is Echinella corrodens, and K is Kingae. Well, I added that, but yes, that's it. I think a couple of these changed names, right? I think the A and C changed names. Let me know what your thoughts about it are. If they changed names like within the past decade or something. We will look it up later. That's pretty low yield. And this last question is a 57-year-old man, and this one is just wanting to see if you can detect a popliteal synovial cyst that was ruptured. So it'll give you symptoms such as some peripheral edema, but there will be fullness on the posterior aspect of the knee when the leg is extended. And the fullness is, yes, of course, because the cyst is there. There can be, what else? Let's see. So popliteal Baker cyst. Etiology is extrusion of fluid from knee joint space into semimembranous or gastrocnemius bursa. Risk factors are trauma or underlying joint disease. Clinical presentation is asymptomatic bulge behind the knee that diminishes with flexion. Posterior knee pain, swelling, stiffness. Complications says venous compression, leg or ankle swelling. Dissection into the calf causing erythema, edema, or positive Hamann sign, and cyst rupture, which can generate acute calf pain, warmth, erythema, and ecchymosis. Okay, so what else can we say about this? That's about it. Most of these popliteal cysts are asymptomatic, but in the setting of symptoms, we already know what are the main findings for it. And that's it for this question. Gonna take maybe a brief nap and continue with another block and take the dogs out. And that's it for this one. So comments, feedback, opinions. I know I wasn't so lively as in other videos, but I want a little nap. So let's get at it. See you later.